If people can gather in and take their seats, I think we'll get started in the next few minutes. Thank you. Good morning. I think we'll get started. I'm Dr. Thomas Shimshak. I want to welcome you to this morning's session on renal denervation. This is a very hot topic in interventional vascular medicine, and we have a very excellent program this morning. I want to begin by introducing Dr. Mark Goodwin, who will discuss the pathophysiology of arterial hypertension and how renal denervation works. Mark.
Good morning. Before I start, just a brief word about, for some of you younger guys, if you get a chance to have a beer with Dr. Woolley or Dr. Matajmi or Dr. McNamara, I advise you to. They're fairly modest. I don't think you understand the criticisms they were under when they were trying to advance their careers. Dr. Matajmi is the one who taught me and trained me in peripheral back in the late 80s. Within his industry, at times he was shunned for having trained a cardiologist. He had three things. He said if someone has the right aptitude, the right talent, and the right commitment, nothing should interfere with their ability to do the procedure. So a personal thanks to Dr. Matajmi. So now we'll get started on what I think is a pretty exciting and innovative field for the future of taking care of our patients. This is my disclosure statement. So this is sympathetic imbalance, but basically we have the acute adrenergic, which is for survival, but chronic stimulation of the sympathetic tone is bad for us. So we don't want to get to a situation where we have no sympathetic tone, otherwise we won't survive. And on the other hand, chronic stimulation, as I'll show, has a lot of negative deleterious effects. The control of the sympathetic system, there's chemosensors and mechanosensors with afferent pathways. We have the effect of high sympathetics on hypertension, dyspnea, sleep apnea, hypertrophy, and chronic kidney disease. So clearly over time, high sympathetic tone has a negative effect on us. And just think of our own lives, what we see in our own practices. We see it all the time. Stress manifests itself. Stress is basically chronic increased sympathetic tone. And it manifests itself in a lot of different diseases, from arrhythmia, anxiety, and depression. Interestingly, there's a study out of Norway about 3 years ago that looked at anxiety and depression patients have a lower average blood pressure than the general population. But vasomotor tone, atrial fibrillation, depressed immune system, hypertension, obesity, Takotsubo cardiomyopathy. I probably went 20 years and didn't know I was seeing Takotsubo cardiomyopathy, and now all of a sudden I feel like I see it once a month. Sticky platelets, migraines, inflammation, ulcers, probably related to changes in histamine release in the stomach, but maybe also increased vasomotor tone to those arteries so they don't heal as well. Irritable bowel syndrome and ulcer disease. Obviously, the predation of this goes back a long time. A lot of time in medicine, we reinvent the wheel. So when you look at the Journal of American Medicine, back in 1933, look at the number of patients. This was not some small little study on a splenectomy for removing sympathetic tone. It was a huge study. The problem is it worked. It lowered blood pressure, but it was hard for a patient to stand because they had such severe orthostatic hypotension. In our own world, there's a guy, Elliott, a cardiologist out of Colorado, who wrote the standardized mental stress test. And I only bring this up because a lot of things are being revisited in terms of this whole idea of sympathetic tone. Dr. Elliott created the standardized mental stress test. He wrote a book in 1989 called Is It Worth Dying For? And he took bioimpedance from NASA and applied, he was one of the first guys to apply bioimpedance for how we look at resistance of skin and vasomotor tone in patients. Our group actually adapted that. We had a wellness clinic, and we would put people who were, quote, hot reactors or resistant hypertension through it. One example was a hospital administrator. She had normal blood pressure. When she would do math, her blood pressure would go to 240 over 140. You submit these people to cold water immersion, math, and video games, and it's remarkable how high their blood pressure gets. A hot reactor is not a type A personality. You can have a perfectly calm exterior and be churning underneath. Fly out of Norway in 2007 looked at patients who were entering the Navy in Norway. And ultimately, at the end of the day, he followed them for 18 years. It was a group of about 300 patients. Blood pressure, the only thing that predicted the development of hypertension, what your blood pressure was at age 18, maybe 19, whether you had a family history and whether you had a positive mental stress test. My point is that stress, or our sympathetic tone, has a long-term deleterious effect, not just immediate short-term. So basically, there's been sympathetic tone modulation for quite some time. Exercise, we know, increases vagal tone, also decreases catecholamines. Yoga increases vagal tone. You hear mind over matter. A lot of theories going on in the peptide world of that mind over matter is that we have the limbic system, which is the acute response, our gray matter, and literally meditation and things like that are trying to control those immediate impulses that are hardwired within our brain. Medications, you know, Respirate is actually approved for treating hypertension. It's a way of basically meditation, teaching you how to breathe. It's actually approved by Medicare. And now renal denervation. Well, what led to this? Well, obviously all of us are frustrated by a large number of patients that don't respond to treatment. They have a failure of current multi-drug approach from the US, Canada, pretty much across the globe. There's a high low response rate or a high number of patients who aren't adequately treated. What is resistant hypertension? This is just so we know the language that we're using. It's blood pressure that remains above goal in spite of compliance with full doses of greater than 3 antihypertensive medicines of different classes with at least one a diuretic. It can also include those patients who require 4 blood pressure medicines to be controlled. And the reason that's important is a lot of the studies right now are dealing with resistant hypertension. Classes of resistant hypertension. We talk about improper blood pressure medicine and misclassification, exogenous substance, too much salt, food, alcohol, complicated biological factors of sleep apnea and obesity, and failure to adhere to medications. So we have to exclude these before they get into the technical resistant hypertension, which is why some of the enrollment is difficult in the studies because you're excluding a large number of patients here. The key considerations in hypertension, as you all well know, first is renal angiotensin aldosterone system, volume regulation through sodium fluid balance and aldosterone, sympathetic nerve system, comorbidities, and obviously genetic factors predispose to hypertension. This, I think, is probably the most important thing for you to take away, that central sympathetic drive is elevated in multiple types of hypertension. So it's not just there in resistant hypertension, but almost across every type, even the high normals, quote unquote, or the white coat hypertensives, almost every subset other than normals has higher sympathetic tone. Renal sympathetic activation in patients with hypertension, you can see once again in the younger groups tends to be a much bigger issue than in the older groups, which is sort of would make sense. Elderly population tends to be sort of a stiff pipe hypertension. And this is what led to the development of the procedure itself. The anatomy of the renal artery, basically we all know, the lumen, endothelium, media, and then the nerves. And when looking at the study of where the distribution of renal nerves are, you can see that they are approximately slightly more distal than proximal, but about equal, proximal, middle, and distal third of the artery. And the depth in the first very shallow to 0.5 millimeters, not a lot of renal nerves. And once again, you're going to get about 80 to 90% of the nerves within the first 2.5 to 3 millimeters of the artery. And this is confirmed by 10 autopsy cases of renal arteries, looking histological slides, and looking once again, if you look at the depth, the total number of nerves, you can see that it's about equal, proximal, middle, distal, and you're going to get most 90% of the arteries with less than 5 millimeters depth. So the first catheter was reversed was the Arterial system, called Simplicity, and basically it was a series of radiofrequency ablations done 4 to 6 2-minute treatments per artery. So each one of those burns is about a 2-minute procedure. And you move the catheter to rotate it. When you finish it, similar to that picture there, you frequently see a little bump in the artery, which I'll talk about. As a proprietary RF generator, low power and built-in safety, make sure you have enough impedance. This is the zone of RF treatment. So basically what we're trying to do, we're not going to get every nerve, but we are going to get a large portion of the nerve, since a higher propensity of them tend to be closer to the inner portion of the adventitia. This is a vascular reaction to after catheter application. You can see the little bumps that I talked about in the middle picture within the artery itself, and you can then see that they heal. Looking at OCT, you can almost see a little flap within the artery. Obviously, the first concern, whether there would be any long-term complications from this. As it turns out, so far, there's not been any long-term incidents of renal artery stenosis or major issues with the renal artery itself. And if you look at the histological side, you can see that the artery does a tremendous job of repairing itself after the ablation. The nerve vascular morphology, if we look at staining of control, acute, and 10 days, you can see that the fascicle is normal in a control, what it looks like in the acute phase, and then chronically you can see that the vein becomes scarred down, or rather the nerve. And if we look at neurofilament proteins, which implies the active component that the nerve is actually functioning, you can see a lot of take-up of the stain in the control with the dark tissue. The acute is fairly there, but at 10 days you see very little active neurofilament protein, which means essentially those nerves are dead at that moment in time. We don't know, are these going to regenerate 5 or 10 years down the road? We do know that data out to 3 years looks pretty promising. So if we look at renal denervation, efficacy and safety, at this point we can say that there's no stenosis or lumen reduction seen in any artery treated at 108 days initially in pig trials, and essentially that's been true in humans, other than I know of one dissection that occurred during the Simplicity, which was just a catheter-induced dissection. If we look at renal norepinephrine spillover, once again, now more data just confirming what we already know about high catecholamines and how we're going to try and manage them. On the left side, there was a 75% reduction, and the right side, an 85% reduction in renal norepinephrine spillover. So Simplicity itself, first clinical trial program, was first in man, Hypertensive 1. Then there was a series of pilot studies, then Simplicity 2, which occurred in Europe and Australia, which is really where this has really got its initial foothold. Simplicity Hypertension 3, which we just completed enrollment, is just completed enrollment now. And there's other areas which I'll be talking about in a later lecture that will be investigated down the road. You get a redundancy to these slides. This is Hypertensive 1. You can see that they're at 6 months, 1 year, 2 years, and 3 years. There's a persistent, sustained decrease in blood pressure compared to controls. And once again, this is a very difficult group of patients. It's resistant hypertension. They're already on 3 or 4 drugs. The 1 to 3 year result, the magnitude of blood pressure reduction was significant compared to baseline. Responder rate did not decrease over time and was sustained. I think that was probably the most important thing. There's one thing if you have a short-term improvement, but a long improvement I think is hugely advantageous to this whole field. If we look at HTN2, once again, small numbers. It's hard to believe, a multi-billion-dollar industry has crept out of basically 106 patients being randomized, but essentially that's what you'll see, as you see from some of the future talks. 52 got RDN, and 54 went to control. Once again, superior to medical management. Average 32 millimeter drop. 80% of RDN patients had more than a 10 millimeter drop in mercury. So in Simplicity 2, we had subject patients with blood pressure at 30 months. Blood pressures were achieved reductions, and after 30 months of follow-up, there's no serious adverse effect, and clearly the RDN group, renal denervation group, did better. Simplicity 3, which is completed, Simplicity Hypertension 3, enrollment is complete. It basically was randomizing 2-to-1 were ablation versus sham, and after 6 months, if you're randomized to the sham procedure, then you could have an ablation, obviously being unblinded at that point. And Hypertensive 4 is going to be moderate hypertensive group, and enrollment of that will start certainly. I'm not going to cover these because another conference, but basically other devices exist, Enlightened by St. Jude. Once again, you're getting the same idea of the same curves and improvement in blood pressure. Vessix, which will be a talk about shortly, and the study will be starting in the U.S. I think they believe it will start by the end of this year for Vessix in the U.S. I just want to show you a simple case of the OCT, because I think everyone's fear is, are we damaging the artery? We've been so concerned about balloon angioplasty and the effect on restenosis and intimate proliferation. And for whatever reason, you can see the artery before ablation and after ablation. And as I showed you, long term, there's a healing process that tends to occur. And if we look at it from a nephrologist viewpoint, what happens to renal resistive index after RDN? You can see there's a dramatic improvement at 6 months of renal resistive index, which means that there's going to be improved flow within the kidney itself. So all of these would suggest that's a good parameter for protecting the kidney from renal dysfunction, and also we're going to get lowering blood pressure as well as potentially improved function for the kidney. These are the first ones now. I think there's probably 50 or 60 patents available. Anything from one patent is you put a needle into the artery and you inject guanethidine into the artery wall. The major ones at this point, I think all approved in Europe at this point, are Simplicity, Paradise, One Shot by Covidien, Enlightened by St. Jude, and Vessex, the V2 device at Boston Scientific. Other ones need to be available. A study starting end of this summer, probably this fall that we're in, is a baroreceptor modulation. Any of you who've done carotid stents know that about 20% of patients have a huge drop in blood pressure. This is just taking advantage of that using a stimulation of the baroreceptor. This next is Cibium. This is Paul Sabatka's, he was medical director of Arterial. He's now medical director of Cibium. And this is basically carotid body modulation. They believe that the carotid body is more important than any place else. You ablate the nerve of the carotid body. The carotid body function is related to mortality and heart failure. When you have dysfunction of the carotid body, there's a lot of chemoreceptors in the carotid body, not just pressure receptors. Carotid body function works in both heart failure and rabbits. CBM reduces RSNA and yet preserves response to stress. And the important thing is CBM triples the effect of RDN for hypertension. So at least in the early studies, a dramatic improvement in blood pressure by ablating the carotid artery. This is something you need to be aware of. This is the number of procedures anticipated by JP Morgan. You can see the number of procedures continuing to rise as we expand this field. In conclusion then, chronic increased sympathetic tone has multiple adverse effects. Other therapies that decrease catecholamines lower blood pressure. Renal artery denervation has a sustained decrease in blood pressure in patients with resistant hypertension. Larger ongoing studies will evaluate the efficacy and safety. Ideal patient group yet to be determined, probably will be expanding, and multiple devices will be available in the future. Thank you very much.
We're going to do the the pre-recorded case, which will be narrated by Dr. Wiffle, and then he will be available for some commentary after the case is presented. I'm going to ask Dr. Woolley to also join us at the panel for some comments.
Good morning. Welcome at the Cardiovascular Center Aalst, which is located in Belgium. It's an honor for me and my team to present you a renal denervation case with the VESIC system. Next to me is Dr. Stelios Pixaras, our research fellow, now since more than 1 year involved in the renal denervation program. Next slide, please. The last 2 years, we have established a renal denervation approach by means of a renal denervation team in our hospital. In that team, a clinician in our institution, it's a nephrologist, a clinician who is taking care of this patient cohort of difficult to treat therapy-resistant hypertension. He is actually in the driver's seat and decides which patients are being selected for this procedure. In that team, there are also a team of interventional cardiologists, and 2 of them are standing here, of course. I give the word to Stelios, who is going to present the clinical case and walk us through the data of this patient.
Thank you very much, Eric. So this is a 72-year-old male patient which has hypercholesterolemia, diabetes as cardiovascular risk factors, and of course, a drug-resistant arterial hypertension. He's under multiple medical treatment. He's taking amiloride, hydrochlorothiazide, calcium antagonist, sartan, a central neuron inhibitor, and a spironolactone. So his cardiovascular medical history is consistent with paroxysmal atrial fibrillation. Next slide, please. The office blood pressure measurement was consistent with very elevated blood pressure measurements, above 200 and 110 of diastolic pressures, while the 24-hour blood pressure measurement confirmed a non-deeper pattern. Let's next slide, please. Yes, next slide. The laboratory examinations did not reveal any dysfunction with respect to the kidney function. Next slide, please. We perform also a magnetic resonance of the abdominal aorta and the kidney arteries that had no significant abnormalities. We find, of course, a significant stenosis in the left iliac artery. This was the reason we chose the right femoral approach. Next slide, please. So in summary, this is a 72-year-old male diabetic patient with multi-drug resistant arterial hypertension, a preserved renal anatomy and function, and the strategy of choice is, of course, renal denervation. Thank you very much.
Thank you very much, Stelios, for this explanation of the patient. What we have done so far offline, so to say, we made a non-selective abdominal aortography, as you can see, in which we excluded significant renal artery stenosis. And as you can see, we have no important polar arteries. We have smooth renal arteries ready to be injected selectively. Yes, next please. In this image, you can see that we have made a selective renal angiogram in order to perform a QVA, measuring the vessel in order to size the balloon accordingly. Now we are ready to prepare our device. The device is a balloon catheter. There is a standard balloon preparation, nothing difficult in it. But I'm going to show you outside of the patient what the system looks like once inflated. This is a 4mm balloon, so we're not going to use this in this patient. But why don't you inflate it, Katja? We go into inflated, low atmosphere until 3 atmosphere, as you can see. And with that, the balloon is inflated, and you can see 4 electrodes. There are 4 bipolar electrodes on the balloon because it is a 4mm balloon. In a 7mm balloon, it'll be 8 electrodes present. So that's concerning the device. Let's go to the patient now. We are ready to insert the device now in the patient. This is the 7mm balloon with the 8 electrodes on it. Prior to insertion, you can see that the console is waiting for connection. As soon as the catheter is connected, which we will do now, the device recognizes the catheter and tells us, okay, this is a 6 or a 7mm balloon. The device itself doesn't touch anything. So the console, the electrodes on the console, do not change colors. As soon as the electrodes do touch the renal artery and we have good contact, the colors will change. So we are in the stage of introducing the balloon in the renal artery. It goes quite smooth. The trackability is good. We enter the renal artery, and as soon as we're in, we're going to make a shot to see where we're exactly localized. Let's go. Okay. As you can see, we're just in front of that bifurcation. We do not want to hit the bifurcation, so I'm going to pull it a bit back. Ça va. Let's give a little bit of contrast and film again. Yeah, this is exactly the spot that we want it to be. So in the distal part in front of the bifurcation, and we are going to inflate the balloon, low pressure, until 3 atmospheres. While doing so, you will notice that the color of the electrodes on the console will change color from yellow, which means doubtful contact, to green, which means good contact. If the electrode has no good contact and it stays for a few seconds yellow, it will not deliver any energy. But here we have good contact, I suppose. Roger, we are going to activate the system as soon as we have done a control angio. Here we are, and we are sure there is no contrast passage alongside the balloon. We have good contact, so we are going to deliver the energy. Why don't you activate the system? So, the system is activated. In the meantime, I can tell you that in our institution we have adopted the habit of doing this procedure under anesthesia, ensuring that the patient is comfortable at the table and does not move while applicating the energy. There is, during the radio frequency ablation, some mild discomfort in some patients, but other patients do experience some pain. That's the reason we adopted the strategy of doing this procedure under anesthesia. So, we have delivered our energy, we are deflating the balloon slowly, and then the goal is to do a complete longitudinal and circumferential ablation, and doing so we still need to deliver the energy at the proximal and ostial part of the renal artery. So what we're actually going to do is pull back the balloon. Part of the balloon will be in the aorta. Part of the balloon will be in the renal artery. We're going to inflate the system, and you will see that the part of the balloon in the aorta, which does not make any contact with the wall, will not change color, and we will not deliver energy there. So why don't you hold the wire, then I can pull back the balloon.
You don't have very much space, do you? It's only little.
Okay, but we'll just pull it back here. Here we are. Let's make a film. Go. So you see the first part of the balloon is in the aorta, and the distal part of the balloon is still in the renal artery. We're going to inflate it and deliver the energy at the proximal and ostial part. Okay, Stelios going to inflate the balloon. We're going to film this for you guys. Okay, the balloon. We have good contact here. The first 2 electrodes are well against the wall. So, and we're delivering the energy. So, we are deflating the balloon now. And as you can see at the console, we have activated 3 of the 8 electrodes. We went up to 68 degrees Celsius for 30 seconds, delivering an average of 1.2 watts. So, deflating the balloon, ready to take it back into the catheter, fixing the wire, trying not to lose the system. Okay, we're slowly in the catheter. Ça va? And we're going to make an injection, Stelios. Ça va?
Yeah.
Contrast, please. So, and this is the angiogram of the right renal artery. As you can see, we started with a smooth vessel and we're ending with a smooth vessel, no problems whatsoever. We're ready to move to the other side. So we move to the other side, to the left renal artery, wiring it, and now introducing the balloon, slowly introducing it into the renal artery. Okay, we're in. Let's make an injection to see where we are. Okay, here we are.
Just a bit more distal.
We can go a little more distal, Stelios, yes. Just avoiding the bifurcation. I think we can move on here. It'll be okay, I think. Let's... Yeah, this is great. Why don't you inflate it? So, again, inflating the balloon slowly to 3 atmospheres. You can see the balloon expanding. We're going to give some contrast, showing you that there is no passage of contrast via the balloon. You can see at the console the colors of the electrodes all changed from gray via yellow to green, telling us that there is a good contact of the electrodes with the vessel wall. Roger, why don't you activate the system? And the system is activated for 30 seconds, delivering in a bipolar way the radio frequency energy. So, we have delivered the energy. Stelios is slowly deflating the balloon. I'm giving you Scopy. Slowly the balloon is being deflated. In this artery, I'm sure that with this position we have done a full denervation. No need to pull the balloon back to the ostium. We have a very small rim of ostium left. I don't think we're going to deliver more energy or do a second application here. We're going to pull the balloon back, make an angiogram, and ensure that we have no problems there. Pulling the balloon back in the guide system goes without any difficulty. So, and now we're going to make the angiogram. Okay, here we are. Again, we started with a smooth vessel and ended with one. All 8 electrodes were activated. We delivered the energy of 68 degrees Celsius for 30 seconds, delivering an average of 0.7 watts at this stage. So we're confident that with the system that we showed here, we were able to do a complete denervation, circumferential and longitudinal, in a easy, fast way. Thank you.
So it's my understanding that Eric will be available by telephone. Is that correct?
Yes, I am. Good evening or good morning for you.
Good morning.
Good morning.
Thank you very much for a really elegant demonstration. This is Tom Shimshak. I'm joined at the panel by Dominic Alaco, Mark Woolley, and Mark Goodwin. And I understand you want to make some additional comments first, and then maybe we can just have a few moments to ask you a few questions, if that'd be okay, Eric.
Yeah, sure. Well, why don't you raise the questions that you had in mind?
Well, I'll take the moderator's prerogative and ask the first question. Are you aware of the data with this particular technology in terms of the surface area of the burns itself, as well as the depth of penetration compared to some of the other technologies? Is there a significant difference with this platform compared to some of the other devices?
Well, the difference in relation to the other technologies is in the ease of application. At the first results that we know of the data that we presented on EuroPCR show us that it's the same efficacy as the Arterial system, and that there are no major adverse events in the patients being treated. I think that's the most important thing to highlight. Right? So it's easier to use, in my opinion, and the results in the patients being studied are pretty much the same.
Okay. I was impressed by the ease at which that catheter was introduced on both sides without a lot of guide support. What wires do you tend to use? Do you need an extra support wire, or what type of 014 wire do you use?
It's an extra support wire. I think in this case it was a BMW heavyweight, but and then the guide sheath has a double curve shaping, and well, as I said, the trackability and the ease of introducing it into the artery is quite easy.
Good. Do any of the panels have any?
The procedure itself is not that difficult. It's the identification of the good candidate which is the real challenge in this procedure, I think.
Eric, this is Mark Goodwin. Great job, and obviously pretty exciting. There was an article about a week or 2 weeks ago, though. It was first real negative. I wouldn't even say negative, but maybe put a little water or dampen. It was a working group out of, I think, Belgium, Netherlands, and Germany that looked at ambulatory blood pressure and renal denervation and said that there was a long-term only a 9 to 10 millimeter drop. I don't know if you're a part of that work group or saw that study, and if any comments you could have about that particular paper.
Could you rephrase the question? I kind of missed half of it.
Can you just repeat just this?
The question was, there was a working group out of Belgium last week that was called the Renal Denervation Working Group, and it was out of Belgium, Netherlands, and Germany that looked at a long-term group of patients at about a year, and they reported only an average of 9 millimeters mercury drop. And I was wondering if A, you were part of that working group, or B, if that's been your own personal experience with renal denervation.
Well, I was not part of the working group, but I'm aware of the results. The long-term results in the real world are not that spectacular as that were first shown in the published studies, that's for sure. Yeah. In my humble experience myself, our long-term follow-up does show efficacy, but not to the same extent as that was published in the literature.
Eric, I think Dr. McNamara has a question or comment.
Can you hear me? Tom Shimshak will address this perhaps, but what crosses my mind as I watched your demonstration is that the anatomy showed, to my eye, no atherosclerotic disease, which in the patients I examine is rare. If the patient has some either ostial or proximal segment atherosclerotic disease, not judged to be hemodynamically significant, but nonetheless there, are the results adversely affected by that?
Well, in the patients that I treated with mild atherosclerosis, and I have to underline mild atherosclerosis, the results are pretty much in line with the patients without any atherosclerosis. But classically, the occurrence or the presence of important atherosclerosis is a contraindication for renal denervation. This being said, I have treated a number of patients without any difficulty with atherosclerosis, with mild atherosclerosis.
The other question I would have is and Tom touched on that, from a delivery system and stability system, particularly if the patient has a little more angulation at the origin and or some atherosclerotic disease, would the system be compatible with an 018 guide wire?
I don't know.
And how do you choose the diameter of the balloon?
Well, according to the QVA, we do a quantitative coronary angiography and then we size the balloon on a 1-to-1 ratio.
So Dr. McNamara raised another interesting question, and the case that you demonstrated had fairly horizontal-oriented renal arteries. What if there's a fairly steep degree of angulation, disease-free but steep angulation? Is the shaft length long enough that you could potentially do this from a brachial approach? Or do you have to use transfemoral?
We've encountered some difficult anatomies, and in some patients we had to use a body wire, to straighten a bit the vessel, which we removed after we've put in the balloon.
Okay. Well, we're going to hear more about the VESIX trial momentarily, but at this point, I guess I would just ask, in your experience or the experience of the other operators that you're in contact with, what sorts of complications, if any, have been observed? Are they related to the device itself or the catheter manipulation? Can you just comment on that?
Yeah, sure. The possible complications with renal denervation are, of course, the classical vascular access complications, as we all know, the hematoma, the pseudoaneurysms. But this being said, the classical complications with renal denervation that we have to take into account is renal artery vasospasm and renal artery dissection. There are some data. There was a publication from the Templin, from a colleague from Germany, with the OCT data showing us that the majority of patients on OCT shows vasospasm of the artery, and that a lot of patients have edema and even thrombi after the renal denervation. This being said, in our own cohort of 37 patients, I have encountered one procedure-related dissection, which was situated next to a very mild atherosclerotic plaque, and we tried to avoid this plaque with the device, but still after the renal denervation we saw a dissection which we had to stent on the table.
Okay. We have another question from the audience.
One quick question. If there are two renal arteries on one side that essentially, split the kidney into two poles, I'm assuming both need to be treated. But if there's an accessory branch, is there a size limit or a vascular supply, contribution at which point you don't consider it significant enough to treat?
I think this is a very, very good question. As you know, the importance of polar arteries in renal denervation has been highlighted. It's very important to do, if possible, a complete renal denervation. But if the artery is too small to accommodate the smallest balloon, being a 4.0, we refrain from the renal denervation. The same holds true with the Ardian system. If the artery, the polar artery, is less than 4 millimeters, we do not do any renal denervation over there because it's simply not safe enough.
Eric, can I just ask a couple of procedural questions? Can you just comment on the role of anticoagulation intraprocedurally? To what extent do you anticoagulate? And also, how susceptible is the artery with this device in terms of vasospasm? Do you use vasodilators?
Regarding to the anticoagulation, we use heparin with an ACT over 250. In the beginning, 2 years ago, we did not use any anti-aggregating therapy, but we changed that habit since 1 year, since the first OCT anecdotal data became available, that we do induce some thrombus. Regarding to the spasm, I know that a lot of operators call it spasm, but in our opinion, it's not really spasm that you see. It's the tissue edema that you see. And proof of the pudding is that if you administer calcium channel blockers or nitrate, high-dose nitrates in the artery, it does not make any difference to that phenomena. So the majority that we see, that we think is spasm, because we all, as cardiologists, we recognize what we know being coronaries, but in the renal artery, it's more the tissue edema that we see.
Okay.
Tissue edema, which is transient. A lot of those tissue edema is very important, or really catches your eye, but if you wait and you do not stent it, you just wait and you control the patient, 1 day later, the tissue edema is gone. So you have to keep your cool and refrain from unnecessary stenting there.
Okay. We have a few more minutes. Any questions or comments from the panelists? Mark? Well, thank you very much, Eric, for an elegant presentation. We appreciate you being available to interact with us live. Great job. Thank you.
Thank you very much. Bye.
For the Simplicity trial, the person raised a question about the accessory artery. In Simplicity, it has to provide at least less than 30%, ideally less than 25% of any of the amount of kidney supplied by the accessory artery, and that's sort of the criteria for Simplicity.
Okay, thank you. Okay, at this point, I think we'll move on with the program. I'd like to introduce Dr. Dominic Alocco, who will address the results of the European VESIX trial. Dominic.
Great. Thank you very much. I'm presenting on behalf of Dr. Wiffles and will be speaking about the Boston Scientific Vessix renal denervation system and the results of the REDUCE-HTN trial. By way of disclosures, I'm a full-time employee and stockholder of Boston Scientific, the manufacturer of the Vessix system. You've just seen a case presented, so I'm only going to very briefly review the Vessix system. This is a balloon-based technology using a low-pressure, non-compliant balloon. The balloon comes in integer sizes from 4 to 7 millimeters. It has a helical pattern of mounted RF electrodes. The treatment time for each balloon inflation is 30 seconds, with up to 8 RF electrodes being activated simultaneously. And as you've seen, electrodes that are unopposed to the vessel wall are automatically deactivated and no energy is transferred through them. The system uses a temperature control algorithm targeting a temperature of 68 degrees Celsius. It's a very simple one-button operation, and the device is now CE marked and commercially available in Europe. It's also approved in Australia. In contrast to a number of the other systems, the Vessix system uses bipolar RF. This is a relatively efficient means of transferring energy to the vessel wall, and we typically see very low energies used on the order of 1 watt, typically per treatment. The Vessix system has been studied in the REDUCE-HTN program. The initial study was a first-in-man study consisting of 18 patients. Subsequently also conducted the REDUCE-HTN post-market study. This study enrolled an additional 128 subjects. The 2 studies were designed to be pooled and analyzed together. Both enrolled patients with resistant hypertension, and patients had to have a systolic blood pressure of greater than or equal to 160 millimeters of mercury. They also had to be on at least 3 antihypertensive medications at maximal doses. This follow-up for these studies is ongoing. I'll be presenting the results of an interim analysis. We have 6-month follow-up available on 41 patients and 12-month follow-up available on 10 patients. The primary efficacy endpoints included reduction in systolic and diastolic blood pressure at 6 months, as well as multiple other time points in comparison to baseline. The acute safety endpoint was a composite of renal artery dissection or perforation requiring stenting or surgery, renal artery infarction or embolization, stroke, MI, or procedural death. We also evaluated long-term safety and the development of renal artery stenosis. All patients were required by protocol to have renal ultrasound at 6 months. The mean age of patients enrolled in the trial was 59. Approximately 40% of the patients were female. Not surprisingly, there was a high incidence of associated cardiac comorbidities. Type 1 diabetics were excluded by the protocol, but about 32% of patients had type 2 diabetes, 46% of patients had a history of coronary artery disease, and almost 70% were being treated for high cholesterol. The mean office-based blood pressure at baseline was 183/99. The mean renal artery diameter of vessels treated was 5.6 millimeters, and the mean renal artery length was just under 35 millimeters. All patients in this cohort had successful bilateral treatment. Approximately 10% of patients, or 4 of the 41 patients, had an accessory renal artery treated. Most subjects required 2 treatments per side, and so the mean number of treatments per subject was just under 4. As each of those treatments involved multiple electrodes, the mean number of electrode activations per patient was 22, and the mean procedure time was 17 minutes. Most of the procedures were performed under conscious sedation, although a significant minority were done under general anesthesia, particularly earlier on in the trial. The targeted temperature of 68 degrees and treatment times of 30 seconds per balloon activation were measured and were achieved, and the mean energy per activation was 0.7 watts. The 6 and 7 millimeter balloons were the most commonly used balloon sizes, with the 4 and 5 millimeter balloons being used less commonly. Here you can see some of the safety endpoints. There were no procedural complications, with that again being defined as dissection or perforation requiring intervention or surgery, renal embolization or infarction, stroke, MI, or death. There were also no adverse events considered to be related to the device. We did have 2 events that were categorized as serious adverse events and considered to be procedure-related. Both of these were relatively minor events. One was bilateral flank pain, and the other was a hematoma. They were considered to be serious adverse events in that they prolonged the hospitalization slightly. As I mentioned, all patients had renal artery ultrasound performed at 6 months by protocol. One patient had progression of existing stenosis at 6 months, which did not require additional treatment. You can see the baseline angiogram on the left showing kind of mild disease, mild to moderate disease on both sides that has progressed somewhat at 6 months follow-up. This stenosis was outside the treatment zone of the vesic system, and this patient actually achieved a good result in terms of blood pressure reduction, with blood pressure at 6 months of follow-up having decreased by 35/15 millimeters of mercury. Renal function was measured and was stable through the course of the study. Here you see the FIM patients in red, the expanded cohort in the post-market study in purple, and the combined cohort in yellow. And eGFR was essentially stable at 80 from baseline to 6 months. A significant reduction in office blood pressure was observed over the course of the trial. You see the results for systolic and diastolic blood pressure here at 1 month, 3 months, 6 months, and 12 months. Trend towards at least greater degree of blood pressure reduction over time. At 6 months, the mean blood pressure reduction was 28 for systolic and just under 13 for diastolic. The 12-month data was similar, although I'll note that that's based on a relatively small number of patients. But at 12 months, we observed a reduction of 28/11. Patients were required to remain on a stable antihypertensive medication regimen throughout the course of the trial, to the extent that that was possible. And indeed, in most patients, that was. At baseline, patients were on 5.1 blood pressure medications, and that continued and was stable throughout the course of the trial. Again, at 6 months, the average patient was on 5.1 blood pressure medications. In this 41 patient cohort, 4 patients had accessory renal arteries treated. 2 of those were treated with the 4 millimeter balloon, and then 1 each with the 5 and 6 millimeter balloon. Here is just one example of a patient with an accessory renal artery treated. You can see on the left side the main renal artery, and inferior to that, an accessory renal artery. Here you can see the angiogram at baseline of the accessory renal artery. The distal vessel was treated first with a 4 millimeter balloon, and subsequently the proximal vessel. And here you see the pre- and post-procedure angiograms of that accessory renal artery. Very small numbers, but in the 4 patients treated with accessory renal arteries, the baseline blood pressure was 185/93, and at 6 months in those 4 patients, we saw a reduction of 20/11. Again, in only 4 patients, but at least demonstrating the feasibility of treating patients with accessory renal arteries. To briefly summarize the results of the REDUCE-HTN trial, successful renal denervation was performed in 100% of patients. We observed a significant reduction in office blood pressure at all pre-specified time points. There were no device-related adverse events. There were no acute procedural renal artery complications, no strokes, no MI, no procedure-related death, and there was a very low occurrence of adverse events related to the procedure, and those that did occur were relatively minor. So this data, I think, is encouraging. Look forward to being able to present longer-term follow-up on a greater number of patients from these studies, and also look forward, as was mentioned earlier, to initiating a randomized trial with the Vesic system later this year. Thank you very much for your attention.
Thank you, Dominic, for a great review. Can I just ask a couple of questions? What are the determinants in the trial of treating the accessory vessels? Is it the size of the vessel, the amount of the renal parenchyma that's supplied by it? Can you just comment on that?
Yeah, so that's a great question, and I think we don't have a lot of data to help answer when to choose that. It's been a little bit of a judgment call in the trial. Obviously, we're limited by the balloon sizes, and vessels kind of smaller than 3 or 3.5 aren't amenable to treatment. Typically, those blood vessels aren't, probably are less important. But it has been a judgment call based on size of the vessel and amount of the kidney supplied.
And if I can just ask more of a generalized question, it's interesting that in every other vascular bed that we treat, the worst thing that we can do historically is to apply heat energy, to accelerate intimal hyperplasia. What is unique about the renal vasculature that precludes that response? Is it the technology that we're using, how the energy is delivered, or is there something intrinsically unique to the vascular bed?
That's another great question. I'm not sure I have the answer to. I think certainly I and many others, had you asked that question 5 to 10 years ago, would have thought that would be a very likely complication. Just have to say it's something that in general hasn't been observed with a number of technologies and a lot of tests of that hypothesis now. As to why, though, I don't have a good explanation.
But even in the animal models, nothing has really been observed. Yeah.
No.
We had a good question from the audience, was that how was the temperature of 67 degrees determined for ablation?
Yeah, so that's another good question. A lot of that was done based on preclinical assessments of both the duration and the temperature, targeting ablation of the nerves without affecting other structures there.
So I had asked Dominic before the session started about the potential role of cryoplasty. I know that you're not pursuing this as a company, but is there any animal data looking at cryoplasty in this setting? Because the electrophysiologists are using this. We use it in the vascular beds, and it's had good results.
Yeah, another very interesting question. One we've looked at just in a very limited way. I think actually there may be some promise to it. I know from Boston Scientific standpoint, our decision has basically been to focus resources on Vesics and that approach, but one that I think is worthy of further exploration over time.
Okay.
Can you perform this on a previously cemented renal artery or no?
We certainly haven't done that yet, so don't think so.
Yeah, at this point, none of the trials have included patients with previous intervention. So,
yeah.
Okay, thank you very much, Dominic. So let's move on. My task is to review the appropriate patient selection for renal denervation. If I could have my slides brought up, please. So Mark showed this slide. I just want to present this slide and a couple of others just to hit home the point that despite our best efforts, and despite the patient's best efforts, for a lot of patients, we don't do a very good job in achieving adequate blood pressure control. That's true in this country, and it's also true to a varying extent outside of the United States. So there's a large segment of the patient population that's at risk. If you look at those with uncontrolled hypertension and really concentrate on the truly resistant, and Mark defined that, that is an even more challenging clinical subset that we deal with. Well, what's the impact of resistant hypertension? Why is that a problem? Well, it represents about 5 to 10% of the total hypertensive population. There's no question that this group is associated with increased cardiovascular complications and risk. We define it as a blood pressure greater than 140/90, despite taking optimal medications, 3 antihypertensive drugs. The threshold is different for those that have impaired renal function or in those with diabetes. So that's an important point. Mark showed this data as well. Sympathetic mediation is a strong component of the refractory hypertensive patient, varying extents depending upon the level of blood pressure control. So catecholamine output, sympathetic discharge is clearly an underlying mechanism for the refractory hypertensive patient. There's both efferent sympathetic discharge and afferent discharge that interface with the CNS and the renal parenchyma and vascular bed to determine a number of physiologic and pathophysiologic responses: increased vasoconstriction, increased heart rate, contractility, and changes in renal blood flow, GFR, renin, sodium, and water metabolism. So those are the sort of physiologic substrates. So at this point, who is an ideal candidate for renal denervation? And this data is based on a review of the clinical trials that have been completed to date, as well as recommendations from the European guidelines for the use of renal denervation. Currently, systolic blood pressure of 160 millimeters or higher, or greater than 150 millimeters for those with type 2 diabetes, despite treatment with maximal or highest tolerated dose of at least 3 antihypertensive agents, one of which is a diuretic. You have to optimize antihypertensive therapy, and it's got to be sustained, and you've got to document the response in the ambulatory setting. Contributing factors need to be excluded, obviously, and it's important to include in your therapeutic strategy the use of a mineralocorticoid receptor antagonist such as spironolactone. For those patients who tend to be resistant, do have some improved response. We also need to exclude those with pseudo-resistant hypertension, particularly those patients whose clinical blood pressure is consistently higher than out-of-office measurements. So we really need to have ambulatory readings on a sustained basis to really document that these patients are truly resistant. Patients should see a hypertensive specialist. And often that'll be the source of the referral for this procedure. They will exclude pseudo-resistance. They can help in optimized medication regimens and lifestyle modification, which is fundamental to effective pharmacologic therapy, and then exclude secondary causes of hypertension. And then, as was demonstrated in the case and through the discussion, patients have to have suitable renal artery anatomy before embarking on this procedure. What are some of the secondary underlying causes that can lead to resistant hypertension? Clearly, renal artery stenosis, pheochromocytoma, sleep apnea syndrome, and primary hyperaldosteronism. What are ideal renal anatomy? Greater than 4 millimeter diameter, more than 20 millimeters in length, and by virtue of the original trial design, the absence of polar accessory arteries and no prior intervention. Absence of excessive calcification and significant atheromatous disease. In the trials, that was less than 50%. In terms of physiologic considerations, currently the population would include those that have relatively well-preserved renal function. GFR is greater than or equal to 45. And they have to have tolerance to antiplatelet therapy for up to 4 weeks post-procedure. These are the exclusion criteria from Simplicity 3. hemodynamic stenosis greater than 50% or prior renal intervention, impaired renal function, patients who presented and required hospitalization for a hypertensive crisis within the previous year, 24-hour ambulatory blood pressure less than 135 systolic, and type 1 diabetes, just to add to the other exclusions. And then I think if you embark on this technology, you've got to do it in a center that has the appropriate interventional skill set. Operators that have experience in doing basic renal angiography and renal intervention. What is the minimum? Probably about 25 cases per year in terms of renal intervention. Outside of the U.S., in Europe, a number of systems have already been cleared for clinical use, and you'll hear more about those as we go on. The Simplicity device, the Enlighten from St. Jude, the Vesix, One Shot from Covidien, and the Paradise Rear Core. Most of these use radiofrequency as the underlying energy source. The Rear Core uses ultrasound. Mark showed this slide. I show it again just to demonstrate some of the differences and similarities of these technologies, variability in terms of profile, catheter size, and energy level, and clearly differences in terms of design, all designed to basically do the same thing. In terms of some of the early results, if you look at the follow-up, varying periods of time, but about 6 months, on average, if you look at each of these relatively small cohort of patients from each of these trials, there was about a 30 millimeter drop in systolic blood pressure and about a 10 to 11 millimeter drop in diastolic blood pressure over time. This is a suggested follow-up. This is fairly busy, but the bottom line is fairly sustained clinical follow-up at frequent time intervals, corroborated by duplex imaging to reassess the renal artery following this intervention. In terms of an appropriate screening algorithm which can be incorporated into your practice, those patients who present or are referred to you with uncontrolled hypertension, exclude pseudo-resistance, incorporate the appropriate lifestyle modifying factors, and then screen in the appropriate patients for secondary causes. Optimize therapy, and then assess the renal vascular bed and determine if this patient is in fact a candidate for renal denervation. So to summarize, the ideal patient currently for this procedure, office-based systolic blood pressure greater than or equal to 160 or greater than or equal to 150 in the diabetic type 2 patient, at least 3 antihypertensive agents with documented compliance over a period of time, corroborated by ambulatory blood pressure readings, lifestyle modification, exclusion of secondary causes, exclusion of pseudo-resistance, and patients who have preserved renal function with appropriate anatomical subsets. Thank you for your attention.
Dental clinic?
I would say, Mark, we have sort of a virtual clinic at this point. We have a multidisciplinary approach where we've sort of brought in the appropriate subspecialists, but we don't have a formal physical site, but there's collaboration by the subspecialist.
So for those of you who think you're doing it, one of the things you take the steps now is, I think, finding some way of how you're going to screen these patients. There was an article yesterday in the Journal of Hypertension. They looked at a small group out of, I think it might have been Belgium, and they looked at 200 people were referred for renal denervation. Of them, 134 didn't make it, mainly for secondary hypertension causes, most of which is primary hyperaldosteronism. Within our group, we did a computer survey. We had 2,000 patients on more than 4 drugs. They went to our hypertensive expert, Joe Merrick, who has hypertension boards. And I can tell you, by the time we got through the process, we were screening about 150 people to get about to the 9 or 10 that got the procedure. Now, the criteria are very strict for the study, but if you're going to be doing this in the future, the time to set up those clinics is now, so you have the things in place to make your patients eligible when these products are hopefully approved in 2 to 3 years.
Those are great points, Mark. We had the same experience in enrolling for Simplicity. I mean, it's a very high bar for that study, and it required rigorous screening to identify patients. It was a rigorous effort. Well, it's my pleasure to introduce Dr. Mark Woolley at this point, who will address renal nerve chemoablative therapy as an alternative for renal denervation. Mark.
Thank you, Tom, and thank you for having this superb meeting. Yeah, we're interested in a somewhat different approach to renal denervation, and we've been looking at chemoablation with site-specific receptors. So, and I obviously have a conflict in this. So, quite a few of these slides are repetitive, so I'll go through these first slides rather rapidly. Obviously, it's been pointed out clearly that hypertension is a pan-epidemic, and obviously compliance has been a major problem. So, at the present time, there are two current methods for managing renal denervation, and as what you've heard today very nicely presented, energy-based approach, and then secondly, we're interested in a site-specific drug attachment approach. Now, and again, pointed out very clearly, these are closely integrated activity with the central nervous system and the afferent efferent complex, controlling not only blood pressure, but some question of left heart failure, sleep apnea, chronic obstructive lung disease, a whole insulin resistance. So there's a whole set of circumstances tied into the parasympathetic, sympathetic plexus, and we're getting a better understanding of that whole complex as we move ahead. So also mentioned, there are at least 25 companies now involved in renal denervation on the energy side, with RF being primarily the principal energetic activity, but again, high-intensity ultrasound, cryo, a lot of other activities controlling sympathetic plexus. So we'll see what the outcomes of those trials are as we move ahead. But implants, yes, CVRX is one, Rux Medical, and Vascular Dynamics, also in a mechanical implant. So it's questionable, do you really want an implant when you're going to treat hypertension? It's not a malignant disease. The question is, do you need an implant to control the blood pressure? So I have some question about implants in terms of renal denervation. So we're interested basically with a chemoablation as our ablative solutions in the same situations, Mercator and Vincristine, all looking at drug attachments to control pressure. So you've been over this very clearly. You see Arterial really set the bar initially when they were acquired by Medtronic and have done a superb job since then. You've also seen in the Simplicity trial, the results are long-lasting. After 3 years now, with significant improvement in both systolic and diastolic pressure up to 3 years. And again, several techniques I'll illustrated earlier with renal denervation technologies. You can see a whole host of activities occurring, mostly energy-related. Now, baroreflex also, interesting technology requiring an implant, but controlling not only the carotid body, but the sinus receptor. And we know quite a bit about the baroreceptors in the bifurcation of the carotid sinus as well as the carotid body. And we know from carotid stenting, it's a very touchy area, and these patients go into hypotension, and they're on neo for as many as 48 hours before they restore. So there's no question activity at the baroreceptor is a very sensitive area, and no question about its activity in hypertension in terms of long-term control, still to be determined. So, and also again, one-shot balloon, because the energy generated with the heat, the one-shot, which is Covidian, has some control of the temperature by means of irrigation cooling system. So again, skip that. Let me skip that. So ultrasound ablation, high-intensity ultrasound ablation, interesting at the first, but now running into some difficulty in terms of potential damage to the intima and medial structures. So there's some limitations as we look at energy. You know, energy is energy, so it's radiation of some sort. So it's interesting to me that there's so little activity and little damage in the studies on the intima or the media. But early OCT findings are beginning to suggest that there may be some vasospasm question, and a small series of patients where there were thrombotic changes and where there also was significant edema at the energy source site. So minimal signs of some degree of vascular injury occurring, post-procedural cavities on the arterial wall, vasospasm. Some investigators now recommending double antiplatelet therapy. So what has come out, though, in recent European Society of Hypertension study, just recently published, 10 European hypertension clinics, high-volume hypertension clinics, where the office blood pressure of 17 mm decrease was acceptable, but ambulatory blood pressure monitoring was only 5 millimeters mercury. So they felt that the results on ambulatory blood pressure monitoring in this particular study were very unimpressive, to the point where they thought that it's so unimpressive that their question that renal denervation should be limited to a research study only in this just published data, which was startling to me. So then also they thought 23% of the patients had no change in the blood pressure, and 35% of the patients on ambulatory blood pressure had increased blood pressure. So a very conflicting report, small sample size, 109 patients, but in impressive clinics, and included Norway, Sweden, Denmark, and the Netherlands and Belgium. And the author of that was Peru. So we're concerned about this recent outcome. Again, it's a single 109 patient report, but it's startling. It's the first serious report to come out against energy approach to renal denervation. We also know that this ulceration occurs, but again, as pointed out by Mark earlier, that this resolves within 30 days. So the ulceration from RF does show resolution. And again, we also illustrated in one of the other lectures that stenosis was present proximal, just distal to the ostium, but again, it wasn't overwhelming, but it was present, and again, representing only a single report, so again, very anecdotal. So let me skip this here. So why the next generation of platforms? We think that it's possible that we can deliver a drug receptor, specific neuron receptor, to the perineural structures and also control blood pressure. And the way it's done is this. The technology is just a conventional catheter with a balloon on it, and then a micropuncture 25 gauge needle anterior and posterior that perforates the intima, goes to the adventitia, and I'll demonstrate where this adventitial is. So we know in terms of intravascular administration of the neurotropic agent, it's anterior and posterior, and we know that perineural distribution in the renal artery is that when we analyze the distance between the adventitia and the intima, it's almost universally 3 millimeters, 2.5 millimeters, so we know to calculate how we can get to the adventitia and distribute the neural space. And here, diagrammatically, it shows what we're doing here. So that the microneedle then perforates the intima, goes to the adventitia, again, on measurements, and then distributes the drug. And you can see here, these are the axons going off of the ganglion. And on the lower right quadrant, you can see what happens when apoptosis occurs. The axon is totally actually destroyed. Now, the neurotropic drug, we can actually titrate the personal approach to it. In other words, we can use a large dose, small dose, but you can see that the receptor, the neuron attached to the receptor, and then enzymatic activity, this capsase enzymatic activity results in apoptosis of the entire neuron, but primarily on the axon. And here you can see diagrammatically also the receptor is attached to the axon, so it's the efferent axon that we're really looking for to search. Well, obviously, you can't exclude the ganglion, but it's also involved. But basically, that's what it is. It's a neurotropic drug that attaches. And you can see here the effect. You can see here on the left, you can see the structure of the wall, intima, media, adventitia, all perfectly normal. And then you can see after apoptosis, you can see the central neurons actually destroyed, but the perineural space doesn't show any inflammatory reaction from the drug. So from the standpoint of early studies, we think this is fairly efficient. And again, this diagrammatically shows the distribution in distance from the intima to the adventitia across a series of animal studies showing you that most of them are in the 2.5 to 3 millimeter range from the intima. And again, showing you where the adventitia, or most of the neurons accumulate on the adventitia, or just within the adventitia, close to the external elastic membrane. And again, the diagrammatically showing the distribution, how this occurs. On your left, you see the balloon going up, and then the balloon up, and then the needle perforation, and then subsequently we retract the needle pulls back into the delivery system, and then it comes back into the 6' sheath. And again, post-procedure analyzed on a porcine study, you can see the structure of the renal artery is normal, peripheral branches extending almost out to the arcuate level, also all normal, no extravasation, no dissection, no thrombotic changes, at least in the experimental animal. What's also impressive is that the neurotropic drugs have such site specificity that there's a significant drop in the norepinephrine. You can see almost an 80-90% drop in the norepinephrine. And that was our biomarker. And you can see that we can control the receptor activity where a small dose, you can see the control on your left, and you can see a low dose and then a medium dose and then a high dose showing graduated drops in the norepinephrine controlled by the dose of the drug. So again, we think that at least the neural applications with chemoablation also, if the baroreceptors in the carotid body become an important subject, we think that site specificity in the neuroreceptors at that level should be easy to manage with a drug. I think much easier than with an implant. But again, to be proven. So skip this right here. So in conclusion, we think that obviously it's an epidemic. We think device-based renal denervation is probably here to stay, aside from the recent report from the Belgian authors. And we think that it's maybe time to look at some advanced generation, new development, device development. We think that that's possible that this might occur with chemoablation. Thank you.
That's really fascinating, Mark. Any idea about how many punctures you might have to make? I mean, you sort of extrapolate from what's been done with RF?
Well, yeah, I think that with the neuroablation, and understanding the horizontal transfer tissues on the planes, so we think that we're getting, and on the animal we can see that when as small as half a cc, we can see distribution across the adventitia. So I think we're covering up probably about 1.5 to 2 centimeter area.
Wow, fascinating. Okay, Mark is going to return to the podium to review application of renal denervation for other conditions of sympathetic hyperactivity, congestive heart failure, obstructive sleep apnea, arrhythmias, and more. Mark.
Thank you. The next 10 minutes, hopefully, I get to have some fun because this is just sort of trying to tease your brains with what may come from this space. Once again, we talked about we're trying to balance what we need to have, which is acute adrenergic versus chronic stimulation. The chemoreceptors as a very complex pathway, as the other speakers have touched on. And once again, when you look at stress here, just look at all the disease opportunities there are if we can control sympathetic tone. So the first thing, I'm not going to touch a lot on hypertension because that's been covered most of today. Just to touch on hypertension 3, as I said, sham or treatment arms, enrollment is closed. Hypertension 4 is going to look at moderate. And I think for right now we can say it's reasonable data that at least in the early studies, renal denervation works for controlling hypertension. I cited that one study that Dr. Woolley also showed the slide on, only because it was the first real study I've seen that would put a little water on the fire burning for renal denervation. Hypertension 4, as discussed, but now we'll talk about some couple other very exciting things. First is insulin resistance. So if we look at role of sympathetic hyperactivation, causes a change in vascular resistance, and that induces insulin resistance. Insulin resistance, as we all know, causes metabolic syndrome, which can lead to obesity, and then increased cardiovascular morbidity and mortality. Sympathetic hyperactivation may predict insulin resistance, and the vicious cycle continues. Hyperinsulinemia results in a higher sympathetic tone, and maybe one of the reasons that metabolic syndrome becomes sort of its own vicious cycle. In preclinical models, inhibition has shown to improve glucose metabolism. So just looking at this one slide here, if we look at improvement in glucose metabolism following renal denervation, there's a fall in fasting glucose following renal denervation and a fall in C-peptide out to 3 months relative to control. Once again, these are just this talk is going to be more just trying to tease you with some of the directions that this can go in. Let's take modulation of chemoreceptors and possible sleep apnea. So obstructive sleep apnea, the sympathetic nervous system is an activation major contributor. When you have apnea, obviously there's high adrenaline release, which causes hypertension. One of the causes of resistant hypertension, as Tom alluded to. There's a causal relationship between sleep apnea and hypertension. Blood pressure may decrease when obstructive sleep apnea is treated. We've all seen that in our practice. Resistant hypertension then may be particularly common in patients with obstructive sleep apnea, which makes sense. Fairly obese population with obstructive sleep apnea. So RDN for treating sleep apnea, the rationale results in reduction in blood pressure with resistant hypertension by reducing the sympathetic activity on renal blood pressure. The effects of RDN on blood pressure and sleep course and with patients with proven hypertension. And this is just the first study looking at this. Look at the apnea-hypopnea index, and you can see after renal denervation, sleep apnea, the number of apneic episodes out at 6 months was reduced. So now let's look at another subset, arrhythmias. This is one study looking at patients treated with ablation. Part received renal denervation, part did not. And once again, you can see those who received renal denervation as part of their treatment for their AFib ablation had a lower incidence of recurrence of the AFib. Once again, modulating the sympathetic tone after you've done the procedure. So you target to the AFib, but by lowering sympathetic tone, in theory, you're going to reduce the amount of subsequent episodes of atrial fibrillation. These are two case reports on refractory ventricular tachycardia with renal denervation. One was recurrent monomorphic ventricular tachycardia, failed medical therapy. Repeat EP ablation failed. The other one did not do EP ablation, but both these case reports had a reduction in VTAC by Holter after renal denervation. So the last one, which may be the most exciting and the most promising of them, is the whole idea of modulation of chemoreceptors for heart failure. So if you look at heart failure and look at sympathetic activation, each class of heart failure has a higher amount of sympathetic tone. We can sort of infer this by the success of beta blockers in treatment of heart failure, which we already all well established. If we look at norepinephrine levels, there's a higher mortality with higher norepinephrine levels across all spectrums. If we look at symptoms, as we all know, one of the reasons that we get short of breath is not necessarily fluid in the lungs. What determines shortness of breath is either chemoreceptors or stretch receptors in our lung. So if you were able to breathe somebody down to a PO2, you would have to get down to a PO2 of 27 if you could maintain CO2, and you would not perceive shortness of breath. So the issue is there's things we can do on a day-to-day basis before patients have a symptom. By the time they come to us with weight gain, edema, or shortness of breath, we've probably already missed it. But are there other chemoreceptors that are sort of a stimulator that are telling the person they're short of breath before they have any clinical signs? We all have patients who are breathless even when everything is fine from a hemodynamic standpoint. And the reason for this is that obviously there's central chemoreceptors that modulate the perception of shortness of breath. If we look at patients with heart failure with central chemoreceptors, the minute volume changes as we look at this because of central chemoreceptors. So by modulating this, the question is, can we change mortality? Well, we don't know that yet, but we can infer that people who have a high chemoreceptor activation have higher mortality. So we can infer that maybe if we can adjust this, we may be able to change mortality of heart failure patients. I'd like you to think of this as fast and slow mechanisms. I sort of trained in the time of renal and dietary mechanisms. It was the kidney and sort of the heart. But there's a whole sympathetic tone going on that's bombarding the heart all the time. Little surges of adrenaline that are leading to problems with chemoreceptors as well as sympathetic tone that cause sudden changes in a patient's condition. It's why you see someone today, and a week later, all of a sudden, they're getting admitted to the hospital with heart failure, and you ask them about their diet, and their diet really hasn't changed because they've been bombarded by the sympathetic tone that causes sudden changes in their volume. So the potential benefits of denervation in congestive heart failure then would be modulation of central chemoreceptors, better fluid balance, heart rate reduction, a decrease in PVR, improvement in exercise capacity, and a decrease in dyspnea. And overall, perhaps a lower mortality and lower hospital admissions. So two tiny studies, both out of Europe. One is just the REACH pilot trial. This is out of England, 7-patient study, mainly looking for safety in chronic to moderate congestive heart failure. Patients got renal denervation. And what it showed, if you look at the potential benefits, is their exercise distance improved following the renal denervation. There was no adverse side effects. So if we look at the change in pharmacological therapies, in blue you see the amount of drugs that went down for these patients. In the grayish green you see the amount of drugs that increased. In summary, loop diuretics were reduced or stopped in 4 of 7 patients. No patient had an increase in diuretics. Beta blockers were decreased in 2 and increased in 1, and alpha-2 blocker decreased in 2 and increased in 1. This is just a safety study, but at least showed improvement in exercise distance and at least some reduction in medications overall. So inclusion from REACH, no adverse events, small numbers, and obviously further data is needed. This is a study out of Czechoslovakia. Olomouc is a city in Czechoslovakia. It's their first trial. Randomized trial of optimal medical therapy versus renal denervation. New York Heart Classification 3 or 4, bilateral renal denervation. The aims were safety and change LV function. There were no procedural complication. Statistically, there was a change in ejection fraction for the renal denervation group, improvement of EF from 25 to 31, no change in the optimal medical therapy. This, I think, is an interesting slide. BNP, dramatic reduction in the group with renal denervation. This was the only change in treatment. Their meds were kept constant. So their BNP had a dramatic drop by just renal denervation relative to the control arm. Interesting, hospitalization. First study that I've seen looking at hospitalization for this. Hospitalization for heart failure looked to be less in the renal denervation group versus the optical medical therapy group. These were, once again, people kept on the same therapy the entire time. So the small study from Czechoslovakia, exciting trends, small numbers, needs further exploration. In conclusion, I think there's a lot of exciting opportunities. When I show that slide about all the different effects of high catecholamine rate or high sympathetic tone on our bodies, there's obviously a lot of opportunities, whether it's with Dr. Woolley particularly targeting specific nerve endings to specific organs. I don't think we know yet. Whether it's going to be ablation, I don't think we know it. We can say data supports renal denervation for resistant hypertension. There's promising data for insulin resistance, sleep apnea, AFib, and heart failure, and many ongoing studies with much, much more data will be required. Thank you.
Thank you, Mark. So I have the concluding presentation this morning for this session, and my topic is to address what the potential of renal denervation, how you can integrate this and prepare your practice for this technology. Well, as we've heard from all the panelists, I think that this does represent very exciting technology. But having said that, I think it's also fair to say that it's still relatively young. There has been proof of principle, looking at different devices in clinical trials, all have shown some consistency. So that by itself is encouraging. It's always interesting to get Wall Street's perspective. I think it's important to look at this with a couple of caveats. These projections are made in the context of all the potential negative impact of healthcare in this country in the future and based on limited clinical data to date. So as you can see, Wall Street is fairly bullish on this technology, and these are their projections of growth over the next 10 years or so. Well, in addition to patients with resistant hypertension, as Mark has summarized, there are anecdotal reports that the potential of this technology and many other clinical situations, all of which represent challenges for us as clinicians. Patients with significant kidney dysfunction, heart failure, which is a huge healthcare problem, obesity, diabetes, sleep apnea, all of these have shown on a limited basis some response to this technology with favorable clinical endpoints. And therein lies the excitement. So having said that, how do you prepare for this technology in your practice today and in the future? What are the keys to success? The keys to initiating a successful program are not unique to this program itself. The elements of success are similar to any other new program that you would initiate in your practice. You've got to define your objective, understand the obstacles that confront you personally as well as your practice, understand the strengths and limitations of your institution and your own individual practice, and then develop and execute a thoughtful plan. And we'll review some of the elements. I think at the outset it's important to say that renal denervation should not be viewed just as a unique procedure, but rather view this as part of a more global program, a more global clinical program. As an application of a technology, begin with patients with hypertension. That's how it'll be released in this country, I predict. But be prepared to expand this into other clinical arenas as trials validate this technology with larger subsets of patients, and develop a comprehensive clinical program. At the outset, even today, before this technology is readily available in this country, in terms of best practice patterns, reach out to the other subspecialists that you'll need, other cardiologists, hypertensive specialists that may exist on your campus, nephrologists, endocrinologists, dietitians, and pulmonologists. You'll need these people now and in the future maybe even more. Determine the clinical need within your referral base and begin to initiate a hypertensive database. If you have an electronic record, you may have a head start in trying to extract patients that might be candidates for this therapy in the near future. If you don't have a hypertensive clinic or center, think about developing one and integrate the appropriate subspecialists into that clinical arena. Currently, there is no certification or credentialing process that I'm aware of for a dedicated hypertensive center, but I would begin to watch for that because I think that will be on the horizons in the near future. It already exists in Europe. There are hypertensive specialists, and these are the components of what constitutes someone who is a legitimate hypertensive specialist. Demonstrated commitment to clinical experience in hypertension, no less than 10 years in taking care of patients. Training in a medical subspecialty that is germane to hypertension. Scientific activity, publications on clinical hypertension, participation in clinical trials, participation in scientific meetings, and recognition by your peers at a national level as a hypertensive specialist. Begin to create a clinical algorithm, screening patients, instituting the appropriate thresholds for diagnostic studies, lab studies, renal ultrasound and duplex, CT angiography and MR angiography, and develop in that algorithm risk factor modifying strategies. And then refer to a hypertensive specialist if you're not comfortable caring for those patients, and then begin to explore therapeutic options. It's important to assess the vascular lab capabilities, whether in your hospital or in your practice. Understand their capabilities of the sonographer, the equipment that they have at their disposal, and what are operational issues that you may have to confront. And establish that the lab does meet societal standards of performance and is a credentialed lab for doing renal imaging. In terms of your individual clinical and technical proficiency, obtain the clinical foundation for contemporary hypertensive therapy and renal denervation. How do you do that? Literature review, courses like this, didactics, preceptorships. There are many avenues that you can pursue to develop the clinical proficiency and technical proficiency. If you don't have the skill set for renal angiography and renal intervention, you should begin to pursue this soon. Understand the appropriate catheters, imaging techniques for doing renal angiography. Then develop expertise in renal artery interventional techniques with the appropriate tools. Understand the guide wires, guide catheter selection, balloon angioplasty techniques, stenting, coiling. Comprehensive interventional skill set is paramount as you embark on this specific technology. It's very important as you embark on this to understand the credentialing and privileging issues that may exist in your institution and in your department for doing these procedures, and understand those and understand what potential obstacles you may have to confront. Achieve the appropriate training in renal angiography and intervention through courses, proctoring by other colleagues who may have that skill set currently, preceptorships, fellowships, and the internet can be helpful to supplement these activities. Begin to develop an interventional database to track your outcomes and your volumes so that when you are asked to provide that data, you have that. No one else will do it. How do you obtain proficiency with a specific technology? As the technologies mature in this country and they begin to get approved, understand those technology, interface closely with colleagues who may have been investigators or work with the company, and assess the availability of that technology to you and to your institution. Like any new procedure, understand the financial data as you embark on this and make sure that this is going to stand the test of time. Look at the procedure and comprehensive program and solicit the support and endorsement of the hospital. That's true for any new procedure, any new program. Understand the training that's required and then acquire that training. Once you have achieved the technical and clinical proficiency, you need to then begin to market this. You've got to educate physicians, educate the public. You've got to develop the appropriate marketing tools that increase public awareness and awareness of your colleagues. It can be a variety of tools that you use, simple brochures. Correspondence is key, telephone contacts with your referring doctors, written correspondence. A variety of modalities can be used. Track and evaluate your program progress. Understand how it's moving. Is it moving in the direction that you want it to go? And then summarize the procedural and clinical outcomes. I think it's very important to have a clinical and interventional database. So start with the clinical database for hypertension and also have your interventional database. That's important for clinical referrals. You need to understand your volume, look at the downstream revenue that can be generated through your activities if the hospital is watching that. And look at your procedural and longitudinal outcomes and understand the financial data. And then share your performance with your colleagues in your department, other subspecialists, the hospital, and with the community. So to summarize, renal denervation will dramatically change the treatment of hypertension and other sympathetically mediated disorders that we treat. Renal denervation procedures should be part of a more global clinical hypertensive program. The success of the program is dependent on the development and execution of a comprehensive strategy. Thank you. So we've actually done pretty well in terms of time. I think we have a few moments for any questions or comments from the audience or any of the panelists. Any comments? Tom?
It was terrific on everybody's part. Thank you very much. What would be the easiest of the denervations? Perhaps, Mark, you can address this. Renal versus the carotid, or is there any other area that we should, what would be your ranking in terms of ease of performance of the procedure and ultimate effectiveness? Renal versus carotid, and then if you'd expand from that.
You know,
and would one be more likely to have an impact on sleep apnea, for example?
My gut impression is that obviously the carotid body is unique relative to the rest of the world, the rest of the sympathetic tone. And just looking at the impact when you do a carotid stent on patients, it's pretty impressive. The issue, I think, becomes one of safety. I'll tell you, it's still amazing to me that we do this and it's not causing any renal artery stenosis, quite honestly. So I think that balance of efficacy versus safety is going to be the determining factor for carotid. Pacing the carotid body, and we're in that study. Nice idea, but now it sort of seems, are we leaping too far forward that we're now implanting something in somebody as a permanent device just to pace their carotid for hypertension? The renal, I think, is safer, more accessible, easier. Dr. Woolley and I were talking, we're both sort of stunned. All of us have dealt with restenosis. I'm still amazed that deploying heat in this vessel doesn't seem to cause anything. I can't explain or understand. If you were to ask me, I would have thought it would cause a lot of problems, and I have no reason why it doesn't. When we deploy heat anyplace else, it causes a problem. I can't explain it. So I think the carotid probably has a higher efficacy, but I don't know what its safety will be, and that's probably going to be the trade-off between the two.
Yeah. Well, there's certainly a significant.
Just hold it down. You just have to hold it down.
Yeah, there's a significant amount of work now going into the carotid. As a matter of fact, a lot of venture funding now is looking at the carotid because it's so sensitive. But it amazes me when we put a stent in the carotid or a balloon, there's a transient drop in pressure, and most of it occurs. So, and yet it's stent in there with all the calcification. You'd think that causes at least some dystrophic change on the renal, on the carotid body and the carotid sinus permanently, but it doesn't. The patients with their hypertension, they come back to the hypertension within a day. So I just can't put it together. So if we ablate it, I mean, the stent's not ablating it, but the stent's damaging, no question, the stent's damaging the baroreceptor. But also interesting in those patients who had endarterectomy, they don't have any response at all. So, but they're still hypertensive.
It's curious.
It'd be interesting for another thought that occurs to me based on what you just said, Mark, that be interesting to get your remarks cumulatively in the audiences is if you put a stent in a patient who's had a carotid endarterectomy, they have restenosis, they don't drop their pressure. So clearly the surgery has already partially or completely denervated that area. Yeah. Yet I don't hear surgeons or anybody talking about that following carotid endarterectomy, you're more likely to be normotensive. Is that a phenomenon that just isn't talked about, or does it not exist?
I'm not aware of any data that shows it. It's a great comment. You would think that there would have an effect. I'm sure there's probably been studies that have looked at sympathetic adrenaline levels, norepi levels. Maybe they would go down, but I've not seen anything that showed a persistent decrease in hypertension in patients with a carotid endarterectomy.
Yeah, I'm not aware of it either. Any other comments or questions? If not, I want to thank all the panelists for a great presentation. The taped case was fantastic. Thank you all for being here. We're going to take a few-minute break, and then for those that are interested and can return, we'll begin the lunch symposium in about 8 to 10 minutes. Thank you. Thanks a lot. That was really great. Appreciate it. Thank you.